Go.
Hi, this is Guy Odishaw and Fran Bieganek of the Bhakti Brain Health Clinic, and you're listening to the NeuroNoodle Network podcast.
Oh, all right. That's a good
Nice.
omen.
We're on a
Very
roll
good
here.
omen. Very good omen.
The best I've seen so far. So
Appreciate the supports. Need it.
Oh, don't worry. It's uphill now. Thank you all for joining NeuroNoodle's Neurofeedback and Neuropsychology podcast featuring our neuropsychologists, Dr. Laura Janssens and Dr. Skip Wren, and neurofeedback legend, Jay Gunkelman. This is an all-star cast that are more than happy to share their knowledge with you. You can find Dr. Laura at janssens.com. Dr. Skip can be found at drskipwren.com. And Jay Gunkelman, well, there's only one Jay Gunkelman on Google. Please give us 5 stars on Apple Podcasts. It really helps get the word out. If they can't hear us, we can't help them. My name is Pete, and today we're going to chat with Guy Odishaw and Fran. Help me out. Is it
Bieganek?
Bieganek. Okay. Bieganek. Okay. We'll edit that and post too. From the Bhakti Clinic in Minnesota. It's not the Bhakti Clinic now. It's the, what was that, Guy?
The Bhakti Brain Health Clinic.
Brain Health Clinic. Okay. In Minnesota. We had neurofeedback tech guru John Anderson on the show a few weeks ago, and he suggested to bring on Guy and Fran. And I can't wait to hear the show. Guy, Fran, thanks for coming on the show.
Glad to be here.
Good to be here.
How do you guys know John? Okay, you're in Minnesota. What else? You share a wood chipper?
Fun.
Oh, wait, that's North Dakota. Sorry, Jay.
Yeah, that's Jay.
So I'll just jump in for my side of it is, I got interested in neurofeedback probably about 20 years ago when I was at the University of Minnesota. They brought me on to set up an integrative clinic, and we would do these workshops, and I would bring in all kinds of professionals from the community to do kind of alternative medicine workshops for the conventional medicine providers at the U of M. And one of the people that came in was a neurofeedback practitioner. And I have to say that my love of technology and my love of healing came together in seeing what this equipment could do. And that was 20 years ago. And I was impressed. Of course, it doesn't compare to what it can do now. So that led me to John Anderson being, one of the main people in the neurofeedback community here in the Twin Cities. So I reached out to John, started a conversation then about wanting to bring neurofeedback into the clinic at the U. And that really was this on and off again conversation over 20 years as I would call John and say, hey, do you have anybody? And he would say no. And then I would call him in a few years and say, do you have anybody? And he'd say no. And then eventually I decided if I can't find somebody, I'm just going to start doing it myself. And that's where Fran and I teamed up. I reached out to John and said, hey, John, I'm not calling you to ask if you've got somebody for me. I'm calling to ask if you will train us, mentor us. And thank goodness he said yes. And, here we are about 4 years later. And it's been a fantastic journey. But I now understand why for 20 years John said no when I asked him if he had anybody for us. I did not understand what it takes to become a neurofeedback provider. And now I appreciate that what I was asking for and why John would just laugh at me.
Fran, how did you come into play?
Yeah. So, I had been, I brought my psychology practice to Guy's Wellness Center, and I'd been teaching for quite some time and had closed my psychology practice, and then went on sabbatical and got refreshed. And instead of getting refreshed into teaching, I decided I wanted to go back into doing my therapy practice full time. So brought my practice to Guy's clinic, and Guy approached me and asked if I was interested in doing neurofeedback. It kind of neuropsych is something that's always been an interest area of mine, and just for a variety of reasons, that's not the direction I chose to school in. And so was super excited when, guys said, hey, you want to do this? And that's kind of how we began this process of building the clinic.
Now, Bhakti, Brain Clinic, see, I didn't have to write it down. We'll edit that out in post. The wellness center that you have, like, what makes it unique in the area in Minnesota? Like, Guy, you started it with were you just addressing depression, anxiety, or how did it start? How did it evolve? Because it seems to me like it evolved into a holistic center. Am I off base? Set me straight.
Sure, you're heading down the right path. So a couple of things. So I have the Bhakti Wellness Center, and then within the Bhakti Wellness Center, Fran and I have the Bhakti Brain Health Clinic, and then I have Bhakti Acupuncture and Bhakti Mental Health, and on and on and on. Kind of, so it can be confusing with all the different names. But basically, so I've been in practice for 30 years. 25 years ago, I was more on the teaching side. And what would happen is I would have my students come back and talk about their experience trying to find work. And some were successful, most weren't. And what happened after having thousands of students graduate, go out, struggle to make it work, was I began to kind of keep a list of what are the things that help people be successful and what are the barriers. So then I started to design a business that would really optimize for success of the professional, right? Like, how could I put in place kind of plug and play business solutions? Because most people failed on the business side. So how could I put it together, this kind of plug and play at scale business solutions to help providers be successful, really regardless of their profession? Then in that process, I was contacted by the University of Minnesota. They had heard about what I was doing. They wanted to start a clinic. They actually had a clinic, the Riverside Clinic, that they were doing, but it was not going well. And ultimately ended up failing. So they brought me in. With the university's help, we could have built my model. We were very successful. The clinic still exists, even though I left many years ago. What I decided to do was take that model out into the private sector to see, was it a viable model? And so 15 years later, here's Bhakti. We're still around. So I guess it's good enough to last for 15 years, but I don't know that it's viable. So I will say, at pre-pandemic, we had 30 providers. So we had MDs, chiropractors, a handful of mental health providers, traditional Chinese medicine, body work, energy medicine, hypnotherapy. So we had a large integrative group. And we really spent time working together. One of my favorite teams was a acupuncturist, a nurse, Fran as mental health provider, and one of our Reiki providers, all working together with a patient to move them forward. And, particularly happy making story for me is in that particular person's outcomes. One of the more valuable ads was bringing in a Reiki practitioner and seeing what energy medicine could do to shift that person. So it's been fantastic, working within an integrative clinic. But then, of course, my passion, neurofeedback, that has come into the clinic just really, in the last 4 years. And now seeing, the integration of, feedback with things like functional neurology and chiropractic, acupuncture, herbs, mental health is a more common integration for neurofeedback, but bringing in these other ones has, again, just grown my fascination with integrative care as a whole, and then seeing neurofeedback in this paradigm has been just nothing short of amazing.
Got it. Definitely preaching to the choir to this group.
Yes.
So we have practitioners listening to the show. We have parents. We We have new technicians. And one of the headlines that popped up last week was the NFL draft is tonight. So one of the quarterbacks that is going to be drafted pretty high tonight, Justin Fields, he announced that he had epilepsy. We did a show on epilepsy last week. This week, we've seen pro football player, Chicago Bear legend Steve McMichael come out to say that he had ALS. So he goes from being a 280-pound powerhouse now to 175 pounds. And ALS is in the spotlight. And we've never talked about ALS. For the practitioners and then for the newbies just hopping on the show, could we touch on that? Maybe, Jay, could you start it out? Let us know what ALS is, and is there anything that neurofeedback can do, or what can you do to help with the symptoms of it? Because obviously there's no cure.
Sure. Well, first of all, historically, there's been no testing that could identify it either. However, recently they've looked at EEG, QEEG, and they find functional connectivity can actually predict the nature of the physical loss. And the disease goes back. I mean, Lou Gehrig was the first famous name associated with it, but then obviously Hawking's as well. It's a degenerative motor neuron disease. Now, it presents generally in two separate ways. One is the upper limbs, and you lose the ability to do fine motor control with the arms, typically. The other one is a bulbar, and there you lose the ability to speak and the ability to swallow. But it's a progressive motor neuron disease. Actually, it goes back quite a ways in neurofeedback. Back to the late 60s, early 70s, Niels Berbaumer at Tübingen University in Germany used slow cortical potential training to work with brain-computer interface. He was the first one to do BCI, which is a popularized term now. And he taught the ALS patients, while they still could move, how to use their brain to operate a computer instead of using their hands. And at that point, he basically taught them how to operate the X and Y coordinates, and they could click on a letter or click on a word. They then eventually figured out that instead of just using the X and Y coordinates with their brain, they could also use the P300 speller. So you could actually look at a spot on the screen and it would type what you were looking at. All of that's actually advanced quite a long ways at this point. You can see Elon Musk using a brain-computer interface to teach a monkey how to play Pong with their brain only. And quite honestly, I think that monkey's pretty freaking good. I would hate to play Pong against that monkey with my hands, much less brain. But ALS is kind of a brutal circumstance. You have about a 2.5 year from the time of diagnosis to the average length of your life. Now there's a number of people that will make it out to 5 years or so, but it's a devastating progressive motor neuron disease. You can extend your life. The medication that they've come up with extends life expectancy by 3 months. Whoopee, and it's got side effects too. So there isn't really an effective treatment. 5 to 10% of the ALS patients actually have it because of familial genetics. The rest of them have it from something else. Now, historically, they thought, well, it's smoking. And, they've done a meta-analysis, and smoking is a very, very weak association. Much stronger association. You have an 11 times higher probability of getting ALS if you've had traumatic brain injury. 11 times more common with a traumatic brain injury.
Is that why vets get it more often?
I didn't quite hear.
Oh, I'm sorry. Is that why vets get it more often, probably?
In fact, veterans, but also sports.
There you go.
They did a study with soccer players, and you don't think of soccer players as head injury necessarily unless you're a soccer player or a soccer fan. And, headers are a rather significant blow to the head. And then once in a while, you just crack heads with people, but 26,000 soccer players, and they found a higher incidence in soccer players than the general population. So TBI from sports is a very heavy influence over it. And, again, there's some of them that is just familial. Obviously the weakness and difficulty with speech and swallowing, but there's also pain, spasms in muscle and pain, and that's kind of underdescribed. Really, it's a brutal aspect of the disorder. I would suggest that the incidence of frontotemporal dementia in ALS is also really quite problematic. The frontotemporal dementia is seen in about 20% of the ALS patients, and frontotemporal dementia is a loss of your personality, who you are, basically, and people's personality don't get better. Nobody comes in complaining that grandpa got nice. This is people with a negative degeneration of their personality style, and unfortunately, the treatments are really not there. Now, neurofeedback is back into the 1970s, but Elon Musk now has permission to implant not only in some people that have quadriplegic changes, but also ALS patients. I think the problem with his approach at this point is that he intends to hook them up after they've become totally paralyzed. Neil Berbaumer found that you could train them how to operate the computer when they still had some motor function. And after they totally lost motor function, even the intention to move the arms was lost. And you have to have some, Elon Musk basically can identify the movement that the monkey has and then program that without the actual movement, just program it with the brain activity. Well, if there's no intention to move and there's no movement, how are you going to train the computer to identify the movement that's not happening? So I think he's going to have some more difficulty with the ALS patients than he intends to have, because of observations that have been made 50 years ago. So anyway,
hey Jay, for the technicians out there, what's going to present on the brain map? Is there anything to say, oh wow, this could be ALS?
You'll be able to identify it with functional connectivity of the motor neuron system. And you think, well, go to the motor strip, where the motor, outflow comes from. That's like telling me that the keys on a player piano is what's playing it. You've got to have a pianist, not just a keyboard. And the frontal lobe is the pianist that plays the motor strip keyboard. So the frontotemporal dementia is the loss of frontal function, and ALS is the loss of frontal regulation of motor outflow. And it's that functional connectivity that you can see in the EEG. Now, it's a fairly advanced technique to look at functional connectivity with EEG. It's not just looking, oh, look at that wiggly line. There isn't any classical wiggly line pattern that you can say, oh, look at that, it's an ALS wave or something. This is something where you have to extract the relationship between locations and how they're connected using computer analysis of the EEG.
Skip, you want to take the comm?
Yeah, sure. And that's where I was going to go. So thanks for answering that, Jay, on the functional connectivity. It was definitely piqued my interest, but hopefully that translates over to both our technicians and just folks at home. I was going to ask some folks, we were talking, chatting here while you were chatting, Jay, with just comments, and a guy had brought up if anybody had any effectiveness treating some of these issues, or just maybe issues in general with photobiomodulation devices. And I don't know that we've ever talked about those on the show in general. So if you're okay, Guy, can I pass this back to you and just have you maybe discuss those devices and how you guys use them up in Minnesota? And by the way, everybody was talking about their Minnesota connections. I spent my childhood in New Ulm, which is about 30 miles west of Mankato, if anybody knows about that town.
Yeah.
Shell's Beer. Shout out to Shell's Beer.
Yes, yes.
All right. It's great. We got a couple of Minnesota connections
Yeah.
here this morning. It's great. So photobiomodulation, what can I say? I'm a fan. In particular, where it's come up, so I'll just say we've used it orthopedically in the clinic for years, and maybe the primary reason there is inflammation. It seems to have a strong effect on the cytochrome C pathway for inflammation, and reduction of pain transmission. And so it makes sense in an orthopedic way, pretty simple. For us, moving into using it in the brain clinic, that's more of a novel addition to the clinic. We have fewer clients doing it, so I have less to say kind of clinically there. But I've been following the research for a number of years, chatting with Marvin Bierman, who's been really deeply following this and has a product that he's bringing out, the infrared helmet, and separate from the Vialite that's been around for many, many years. This infrared helmet is new to the market, but the idea of being able to change a number of kind of cascades happening on a neurophysiological level of number one, stimulating mitochondria, more ATP production, just putting literally more energy into the system, and how that drives healing. Stimulating glial cells and astrocytes. So you've got a number of things happening there around it's hard to generalize that so much science around each one of these aspects. So I'm going to speak just very, very generally here. The idea of activating glial cells and astrocytes, two reasons. One, what they do in terms of cleaning up the environment and eating up the proteins that will ultimately break down myelin and form amyloid plaques. But not only do they do that in the sense of cleaning up the materials we don't want, the byproduct of that metabolism is to excrete the precursors for the building of myelin. So you've got a number of factors that are happening, and what we think with photobiomodulation is you're getting like an incremental boost in multiple domains, and that's what equals kind of what the research is showing is some pretty significant findings in treating neurological conditions. I've spent most of my time looking at dementia and Alzheimer's, some of the other ones, ALS, Parkinson's, have significant differences, but generally the roots are considered to be similar, which is you have an inflammatory process, you have decreased circulation, you have a buildup of catabolites, and that together creates a toxic environment that leads to the neurodegeneration. And photobiomodulation seems to check a lot of the boxes that can address those pathological conditions that are happening and optimize some of the regenerative features.
And just to kind of clarify, myelin is the insulation, if you will, around nerves and connections, right? It would be similar to an electrical wire. And so if your wire's insulated, it's going to conduct whatever it's trying to conduct. So myelin's a good thing. Lack of myelin's a bad thing. Yeah.
Yes. Yep. Myelin is a good thing for exactly the reasons you said. And then there's another effect that happens. So it can happen in a number of ways, but when the myelin starts to degrade, it looks like what happens is the brain will peg those neurons with a substance called complement. And when they've been tagged, then that tagging essentially sets them for removal. So not only is it do you get a degradation in the electrical conductivity of the neurons where myelin is degrading, right? So they just function poorly, but you also see those neurons get set for pruning. And so this is part of the expediting of the neurodegenerative loss. It isn't just conduction velocities, it's the actual neuron itself getting pruned. So a couple of things happening there around the myelin.
For folks, real quick, for folks who might be interested in what you're talking about specifically, Guy, Seaburn Fisher was on and mentioned a book to us, The Angel and the Assassin, and it talks about the microglia's role in doing exactly what you're talking about on the assassin side. And then on the angel side, it has a way of supporting and helping those same organisms generate. So good book out there. Anybody, Jay, Laura, Fran, on photobiomodulation or the BiLight? Something tells me you know Lou Lin, Jay, but not to put you on the spot.
In fact, photobiomodulation is an emerging application, and it's got lots of interesting case support. There are some small studies, but usually they're quite small. It deserves some funding for actual sizable studies at this point. I work with a group in Korea, South Korea, obviously, in Seoul, a national university, but they've gone private as a business now. They collected a normative database of EEG, but they've developed a helmet that does EEG measurements with a dry sensor, with a fairly advanced dry sensor system. But they also have photobiomodulation at each of the electrode sites. And they're placing a couple of those in some locations in Canada for me to have some folks that are doing some research actually play around with the devices. But they're busy going through the FDA process now. The FDA is generally allowing photobiomodulation as a, well, it doesn't seem to be able to do any harm, so go ahead and make it. And you know that's okay, but you'd think that the FDA would actually look for some kind of a medical outcome, not just, well, you can't do any harm with it, so go ahead and do something with it, you know. So it's really quite promising for the dementias. One of the difficulties that is present in the small studies that have been done is that when you quit using it, it appears that Alzheimer's has a precipitous decline. Now, if you've been holding steady for a long time and not declining, and you pull away the thing that's been holding you steady, you can kind of expect to revert to what you were going to be. But that's a problematic outcome with a small study. It needs to be studied better with larger N and all of that. But it's a very promising emerging application in the neuromodulatory toolkit that people have for, you know, neurofeedback is one tool. Neuromodulation with devices is another way to change brain function. I would urge people to be open to an experimental trial of photobiomodulation. Again, it doesn't seem to be able to do any harm, and it does seem to be able to do some good.
Thanks, Jay. And the devices themselves, just so folks are be aware, when we talk about the photobiomodulation helmet, it kind of looks like a helmet. It's something that you put on the top of your head and you turn it on, right? So from what I've seen, and that's in my practice, but also using it personally, other than positive benefits, virtually no negative side effects that I'm aware of, right? Certainly nobody's going, ow, when they're sitting in the chair, you know?
Correct. You know, again, I've been poring over the literature, not only individual studies, but looking at meta studies and looking at the work of the people who this is their area of expertise. And it seems clear that there are no serious adverse effects that have been recorded. And even the minor adverse effects that have been recorded are something as benign as a slight headache that diminishes within hours post-treatment. So it seems to be very, very safe. How I talk with my clients about this is think about nutrition or exercise as a model for considering something like photobiomodulation. It's a fairly minor nutrient, but when accessed on a regular basis over a period of time, you get a significant outcome, right? Just like exercising, 30 minutes a day, every day, in 2 days, not much has changed, right? You go like, oh, this isn't working. But do that for a month, 2 months, 3 months, 3 years, and your life changes. And this is kind of the model where I put many of the neuromodulations into kind of more of that, kind of nutrition or exercise model. This is a way to think about it.
Okay. So everybody in Alaska is vitamin D deficient. So it would be like taking extra doses of D for a couple months, right?
Right.
But they're
Exactly.
keeping up on them.
Yeah. Yep. Okay. Exactly that. Yep.
So just to kind of close up the discussion on myelin diseases, I mean, there's certainly genetic roots that can destroy your myelin, but we start talking about the acquired myelin diseases, and we talk about ALS, but there's also MS, multiple sclerosis, and that's definitely a condition that can be affected by the loss of myelin. It's an inflammatory issue, and as of now, I don't know that there's any known cause, but I was just going to ask, just in general to everybody, what do you think is destroying the myelin? I don't know, Jay or anybody, if you have any guesses on kind of what is causing this, what's causing the inflammation in these folks. And you said brain injury, certainly if you get hit in the head, I'm sure that's going to, cause inflammation for sure. But I guess maybe the more specific question is, do you think toxins are involved, environmental toxins? Me and Skip are looking into, the toxin, the smog, the electromagnetic smog from, Wi-Fi signals and electricity, things like that. Just wondering kind of if Jay has any response on the root of the myelin disease, the acquired ones.
Well, you end up with autoimmune issues that are attacking, but autoimmune is usually something that's triggered. Autoimmune doesn't generally just jump up out of nowhere. And historically, ALS, for instance, the exposure to lead is a very high correlation with ALS. Now, lead exposure is very high across a lot of things. If you live in Flint, Michigan, you're getting it from your water supply. But the environmental toxins and triggers for the immune system are likely the onset. I have the unfortunate experience of actually kind of seeing neurology. I've been immersed in it for so long. I don't know if you know who Anna Weiss was. Anna did EEG work, but she did guided meditation based on EEG, not neurofeedback, but guided meditation. And watching her walk, I could tell she had a motor neuron disease, and it was 5 years before they could identify the lesions with an MRI. So, when you tell a friend, gee, I think you should go see a neurologist because I think you have MS or a demyelinating disease, and it's 5 years early, it would have been nice to have about 4 years of benign, ignorance about it. But, there's not really much that can be done. There are treatments with beta-seron and interferon, basically. However, not everybody has positive outcomes with that. The single interferon treatment with Anna just about killed her because she had a prior heart problem, and her immune system essentially attacked her heart at that point, putting her into a coma. Anyway, inflammatory changes can end up with autoimmune problems, and inflammation very commonly comes from toxins.
And I'll just throw in the gut-brain axis, where you have, whether it's a virus, bacteria, fungus, or just a part of a virus, bacteria, fungus, or other toxins that are able to make it across the gut lining and then across the blood-brain barrier. I think there's certainly a big appreciation of this happening right now with COVID, and looking at the amount of neurologic side effects, sequelae from a COVID infection, and just a renewed appreciation for, well, our general understanding that the blood-brain barrier kept the brain safe, and then seeing like, yeah, that's not really so true, and how many viruses really are able to cross and then create an immune effect within the brain. So this is one category of causes, is this side, kind of this isn't all that different than toxic, but it is categorized differently when it is a biological entity that crosses, naturally occurring, that crosses and triggers an immune response, versus say heavy metals or pesticides or something of that nature.
Yeah. I appreciate your somatic approach to psychophysiology. I mean, we are kind of an embodied presence, and being embodied, we're not a disembodied brain, that's for damn sure. And the interaction between body and brain have historically been kind of underappreciated by the neurofeedback community. Again, the reintegration with heart rate variability, showing heart and brain interactions, and the heartbeat can actually trigger event-related potentials in the brain. The reintegration of us into a more complete entity ends up giving us a richer approach to interventions as well. So I appreciate your somatic approach.
Yeah, absolutely. I mean, we when our the clinical situation allows, our preferred approach is full 19-channel cap plus a full 10-channel biofeedback setup, so that we're monitoring 19 channels of EEG and the autonomic nervous system same time. Just because of what you just said, Pete, is the interrelationship between the body and how often the body is really driving the anomaly in the EEG, and addressing, say, heart rate variability turns out to be the better intervention than training the 19-channel Loretta, right?
So there's lots of approaches in neurofeedback. Some of them are one-channel approaches or two-channel approaches. Some of them are 19-channel with calculated Z-scores or connectivity measures. Can you kind of describe your clinic's approach to neurofeedback, which I'd call them camps, but they're a little bit more religious, I think, than just a camp. It's like the church of this and a church of that, because it's a really strongly held belief system within the groups. Can you describe kind of your orientation on that?
Yeah, I'll start, Guy, and then you can add on if you want. Guy, our clinic, we feel like we're kind of outliers in the neurofeedback field, because we tend to not choose a camp. So we do 19 channel Z-score training, but we also do 1 and 2 channel and 4-channel amplitude training. We don't stick with one system. We have, we have Nexus, but we now have Neurofield as well. And we just, I think it's part of what is kind of foundational to our brain health clinic, is that we tend not to kind of be pigeonholed in the way that we approach the work that we do with clients. And so it fits for us to just sort of kind of use which approach seems like the more appropriate approach for who is sitting in the chair in front of us. And so we actually find ourselves not being able to put ourselves in one of those camps that you just mentioned, Jay. And I do think that it is, I remember my first ISNR conference that I went to a few years ago, and getting such a clear sense of the fact that there are those camps. And I remember at the time thinking, because as a psychologist, we have camps in the field of psychology, your cognitive behavioral, or your somatic, or, your Adlerian or psychodynamic. And that's always bothered me that, there has to be that one choice. And then I was a bit disappointed when I went to ISNR, and I was like, oh, that's right, it's human beings here. So we're going to camp up, we're going to tribe up, right? But it is, for me, it is refreshing to be able to not feel that we have to be contained within one philosophical bent. It just feels like it opens up more possibilities for providing treatment for or training for clients that will end up giving them kind of the best that we can, right? And what might work best for them. But there's also that, when you're not in a camp, you feel like you're not in a camp. And so that's always a bit of a challenge as well, which is why I appreciate that, this isn't I'm not doing this all by myself, that I have, we have other people in our clinic in this, the camp of not being in a camp. But I think the point for me about all of that that's most important is that it does, it allows us to really continue to consider what is the best line of treatment or training, what's the best approach for each individual that we see in our clinic.
It does allow you to cherry pick out of the Whitman sampler of various approaches which one matches best to your client. And not everybody likes that maple, sometimes the nuts are better.
Yes.
So being able to match up is, I think, really quite ideal.
Yeah, yep. We feel the same way.
I'm wired this way, being the integrative person that I am, and having that as a guiding conception. I will say, one, just as a practitioner, it brings its own challenges of, like in our room, we have split. We have a main neurofeedback room, 2 setups in it, so we could be training 2 people at the same time. And you could be on one side running Nexus and NeuroGuide and network training, in that whole paradigm, and then step over on the other side and be doing Neurofield and amplitude training and what to say, not, like more of an event related potential type of paradigm over against network, and one being kind of running on an FFT or a Fourier transform methodology, and the other running on a Granger causation platform, and be able to switch your brain from paradigm to paradigm. That's its own challenge as a clinician. Your whole rationale for what you're doing and the treatment and what's happening, you have to just shift. The other side of it that is interesting is talking with clients about this, because they don't have all, and nor would we want them to have in their mind all that we have in ours about the paradigm, but yet they ask questions. And you're like, well, okay, I'm going to answer your question this way because you're on this side of the room. But next week, you're going to be on the other side of the room, and the answer to that same question is going to be different. And also just explaining to people about their treatment plan. Mostly what I see is, clients' eyes glaze over because the options are so many that they can't hang with it. It definitely seems easier to say, we do one thing, this is all we do. If you come here, this is what you get, versus we do 18 things and I'm going to explain to you why you're going to get this mix of them. Yeah. So I appreciate the model, but it has this component to it that makes it challenging.
Speaking of one size fits all, or maybe not so much, Fran and Guy, do you mind talking about your philosophy at your clinic in regards to behaviors and brain function? And that's a maybe roundabout way of talking about, hey, the DSM doesn't always fit for everything. It describes, observable behaviors, which aren't necessarily tied to neurological functioning. And as our mentor, Laura and I's mentor used to say, all ADHD ain't the same thing, right? So do you guys mind talking about that? And Jay and Laura jump in too, of course. It's DSM bashing time.
Yippee!
It's not a matter of if, it's when it comes
Yes.
up.
So I will say, like, my students would have said to you, Skip, do not get her going, because this topic is kind of near and dear to my heart, because I think that there's a lot of while the intention of the DSM was perhaps, honorable, there's a lot of damage that happens with it too, because I think that both clinicians and the lay public, right, use the DSM as the Bible, and if it says it in the Bible, it is so, right? And it just simply is. Human being is so absolutely unique that you're right. One person's ADHD is not going to look like another person's ADHD in terms of what's actually going on. Now, from a behavioral standpoint, perhaps, this group of kids all look like they're impulsive. They can't sit still. They blurt things out. They can't focus, that kind of thing. So we put them in that label. One of my biggest frustrations with the DSM most recently was when the DSM-5 came out in 2013. They had prepared us for this move to kind of more of a dimensional approach. I don't know if any of you recall that, but I remember spending hours and hours of prepping coursework for my abnormal psych students to teach them this new approach. And I was super excited about the idea of finally being able to say, see, what I've been talking with you about being on a continuum, that's, what we're doing with it too. And then, in the midnight hour, the DSM came out, and the only thing that was close in there is autism spectrum, right? But we were supposed to have the whole set of personality disorders be on a continuum, on a dimensional approach, and none of that happened. And so I do think that I know that I spend a lot of time, both in my psychotherapy practice, but certainly in my neurofeedback practice, educating clients or uneducating them about the DSM, because they come in with this idea of, even like when you do a QEEG on them, they want you to say, well, does this say then that I do have ADHD, or that I do have, anxiety or bipolar disorder? And so just kind of educating them in the direction of considering what we're doing with neurofeedback is really looking at as you said, Skip, the functionality of the brain, and that is it's the functionality that is going to have some kind of impact on what they're going to experience, on a regular basis. And so I work a lot with clients, training them to not think that they are training away their ADHD or something like that, right? That we are just really training the brain. And so, yeah, I think that the DSM creates a challenge. Now, you know, it serves a purpose at times. It's always good to know if you go into a library and you want to find books on travel, that the travel section's over here, right? But then if you're looking to go to South Korea, you know, you don't want to be in the Britain section, right? That kind of thing. And so I think that's where the DSM kind of falls apart, is it sends you into one category and this leaves you pigeonholed there. And it's been one of the most refreshing things that I've been able to do, is to come into working in neurofeedback, because it just has this way of, we can naturally talk about like the functionality of the brain, and people don't have to get all hooked up in like the psychodynamics of things, or, you know, the family history that is causing this. Well, that may be a contributing factor. It isn't what we're doing with neurofeedback. And there's something for me that's been to come into this. I think I was in my 20th year of practice when I came into neurofeedback. It's been probably the most refreshing part of coming back into doing clinical practice, has been being able to pull this this model of, you know, kind of looking at functionality as opposed to just looking at a set of symptom behaviors.
Well, I have to say that your accent from Minnesota almost is like a Canadian, and you know how nice Canadians are.
Yeah.
So you've got that Canadian Minnesota niceness. Your discussion of the DSM was very good, but also very gentle. I'll put away my spiked hammer here because that's what I would use, and let other folks chat about the DSM as well. I do appreciate the research domain criteria. We published our first research domain criteria paper in 2015 on beta spindles in the EEG corresponding with insomnia, independent of the other psychiatric DSM categories. The largest correspondence was with insomnia. Anyway, I'll let other people feel free to bash away one of my favorite things to pick on.
Jay, I'm guessing you would agree with me that it makes a really good doorstop.
It keeps the outhouse from being tipped over on Halloween,
Yeah.
you know.
Yes,
It's a good counterweight, you know.
yes, yeah.
So
I guess I could get behind it a little more if there was an actual diagnosis in the DSM about not being able to think outside of the DSM.
Yeah.
Right? Like, what do we call that? Like, let's look at function.
that's the normal category they don't have.
Right?
Yeah.
NOS.
It beats the Sears catalog for the outhouse.
Yeah.
Guys, how we doing? We got anything else? Did we get all out of our system? All right.
For this week.
I feel like we need to have an after party now to really get into this.
Oh, yes. That'll be the next time we bring you guys on. We're doing this again. Oh, hey, Guy and Fran, thank you so much for coming on the show.
It was a delight.
Thank you for having us.
Here. Yes.
What's the best way for somebody in Minnesota to get a hold of you? Is it the bhakticlinic.com? Did I have the right Minnesota? Did I get it right?
Yes.
Oh, yeah.
Yeah.
Okay, good.
You sounded like a native there for a moment.
You got to have a couple lilts in the middle. Minnesota. You know, you have to have the uplift at the little lilt at the end of the words in Minnesota. You know, it has to go up a little bit there. But you almost passed for a native.
I'll have Dr. Laura adjust my protocols. So bhakticlinic.com, right, guys? Okay, we'll put a link. I'm sorry, Guy, go ahead.
No, you're absolutely right. Bhakticlinic.com is the best place to find us. We keep our emails, phone numbers are on the site. Everything you need's there.
And I'll put a link on the podcast on the show notes so everybody can check it out. Okay, we thank you all for listening to NeuroNoodle's Neurofeedback and Neuropsychology podcast. Dr. Laura can be found at jansons.com. Dr. Skip can be found at drskiprin.com. And Jay Gunkelman, again, well, there's only one Jay Gunkelman on Google. If you have an idea for a topic, please email me, pete@neuronoodle.com. Please give us 5 stars on Apple Podcasts, smash that like button on Facebook, Instagram, and follow us on Twitter. They can't hear us, we can't help them. Thank you guys so much. Cue the non-copyrighted music.
Thank you.